survive, okay? This is supposed to be the amniotic sac where the fluid is at, okay? So, most of the time when you're in labor, the amniotic sac is going to break, or your water is going to break, okay? Sometimes the water does not break. It's one of these. It's called a finger pot. It's like, you can see it's like a single finger, and it has a little hook on the end of it. Very small hook. And that lets him break the water just by sticking his finger up and kind of hooking the bag. Or he can do a vaginal exam. He can slide this between his fingers. He can grab the bag and kind of pull. And that causes the water to break, or the membrane to rupture, okay? Now, when a baby is born, we want the baby to be head first, okay? It's safer and it's easier if the baby comes out head first. Now, if I'm the nurse and I'm checking the patient, I should feel the head, it should feel like this. Okay. If it feels like this, then it's probably the baby's spot. Can you tell the difference? One of them's very hard and one of them's very soft, right? You tell the difference? Okay, so we want it to be head first. If it's not head first, we want to call and let somebody know that something doesn't feel right, okay? We want the baby to be facing down like this because of our suprapubic bone. That bone goes right here. And so that baby's head has to go through and under that bone. Okay? So, we want the baby's head to be able to go down and flex up to get under that bone. Okay? So this is the ideal position for the baby to be born. Okay, there's several different kinds of medication and stuff that you can use for pain relief during a delivery. You have IV medications, you have an epidural, they do pudendal blocks, which is where they do an injection into the perineum. Sometimes they numb you up so much you can't feel that pressure to push. And so when the nurse tells you to push, you're like, and your face blows up, but you're not getting any pressure down here.
That's always fun.
I've actually seen patients bust blood vessels in their face because they're pushing so hard and they think they're doing so good, but they can't feel here to push. And they need to push like you're having a bowel movement. That's how the pressure is, and that's how you push. If you don't feel it, the doctor may use this right here, which is called a vacuum extractor. Okay? The vacuum extractor, the physician puts on the baby's head. He hands this part off to the nurse. It has a little gun part on it that pumps up like a paint gun, and you can put pressure on it, and it kind of gives the doctor a handle so that he can gently pull since the mother can't feel the push. Okay? It does leave. How many of you have ever seen a baby that's been born that had like a knot on the side of its head? Like a little plump knot on the side of its head. That's caused from this, and it'll be very much the shape of this.
Is it more painful for the woman when they do it that way?
Usually when they're using this, it's because the woman cannot feel anything, and so she's not going to feel it.
Oh, okay.
Okay, I'm going to go ahead and talk a minute about episiotomies so that we don't run out of time and I don't get behind. Most of the time, especially with first babies, they're going to do what's called an episiotomy. Because when that head starts pushing through here, it can tear here, it can tear here, it can even tear up, okay? So it can tear, and when it tears, it's a jagged tear. Okay, we don't want a jagged tear because it doesn't fit back together right, and so it's hard to sew up and it's hard to heal. But if the doctor cuts an episiotomy, then he just has to gently close it and suture it back up. See how easy that is? The straight line, it's much easier to heal than if it had torn. Okay? different doctors have different opinions on whether or not to do that. Okay, Miss Noel just got here. She's told me this is her third baby. She's been contracting for about 5 or 6 hours. I'm going to hook a monitor up to her. One monitor is going to listen to the baby's heart tones. One monitor is going to check the contractions, okay? With the external monitor, you can't always tell how strong a contraction is. So if you've got somebody that's really, really skinny and they've got like a basketball belly, then they can have a contraction that goes woo, like that, and they don't even know they're having a contraction, okay? It's because it's a really mild contraction, but there's nothing in between the uterus and the monitor except for just very little. You have a fluffy person like me, and you put the monitor on, I could have a contraction that just barely shows up on the paper, and I could be screaming and hollering and crying and telling you that I have got to have pain medicine and pulling you over in the bed with me. Okay? So with this kind of monitor, you can't tell how strong it is, okay? You have to listen to the patient, okay? This kind of monitor, you can tell how strong it is. This goes inside the vagina, up into the uterus, and tells us exactly how strong the contraction is, okay? Now, we've got her all settled. It's time to check and see how far she's dilated. Now, can I look down here and tell how far she's dilated?
No.
No. Okay. I need to use my dilation chart to see how far she's dilated. Okay? Now, see how thick that is? And see how thin that is? The more she dilates, the thinner the cervix gets. It's kind of like gummy lifesavers. It's thick, you put it on your finger, you put it on another finger, you stretch it, and you know how you stretch a gummy lifesaver, it gets real thin. As your cervix stretches, it gets real thin. So it dilates and gets bigger, and it effaces and gets thinner. Okay? So I need to find out how far dilated this woman is. So everybody grab some gloves. I'm just about out of gloves.